Thank you very much. So just some initial considerations. I'm purely a pediatric neurosurgeon. My expertise is working with the skull base. So if you think of the skull base kind of as a bowl, so my expertise is working with the bones in this bowl, whether to get to structures or displace it, remove it, and such. Chiaris fall into that category, so Chiaris are part of what I do. The difference is that Chiaris in children are very, very different than Chiaris in adults. The presentations are very different. When we see headache, they tend to be what we call tussive headaches, or headaches with exertion. Curvature of the spine, which is what this discussion's about, is something we see commonly. Buildup of fluid in the spinal cord, or a Syrinx. Sensory changes, a dissociation between fine touch, sharp touch, pressure, those things in kind of the upper back and arms. Those are really the mainstays of what we see in kids. So the diagnosis is much simpler in kids. I'm not certain what happens in adulthood that it becomes so much more difficult and why the symptomatology becomes harder to kind of piece out, but there's no doubt that it acts like a different disease. I'm head of pediatric neurosurgery at the University of California, San Diego. This on the left is our children's hospital. We're actually surgically the busiest hospital in the United States for pediatric surgeries. So the intent of this talk was to basically discuss curvature of the spine and when patients need fusion or stabilization of the spine based upon progressive angulation of that spine. And so I'm going to talk about that in a little more detail throughout, but trying to figure out what things kind of important or salient to us have to do with those progressive curvatures and how to predict when an initial surgery for a spine or spinal cord anomaly can make it so you don't need to do anything else about that curvature, or which things, despite the fact you may treat and operate it on, will still not have an impact on whether they develop a curvature of the spine or not. Many people have tried to explain this. This is my way of looking at it, and I tend to simplify things a lot. I think surgeons like to have things simple, so kind of the way I present this is kind of the way I think about it, and you'll get a sense of my approach with this. One thing you need to understand is all of this is about angulation of the spine, based upon that angulation when you do or you do not fuse the spine. And they're different surgeries. All of these patients have an initial surgery for their neurosurgical or their neural tube issue. Chiari malformations, fatty phylums, lipomatous malformations, two cords which are called diastems, buildup of fluid in the cord, which is a Syrinx. So these are all the things we're looking at that somebody has an initial surgery for. We know that there's a relationship between that initial problem, that neural tube defect, and the subsequent curvature. And that's what we attempted to look at. But the Cobb angle is one of the ways you determine whether somebody needs a fusion or not. And at 10 degrees, that's the minimum that you use to define whether somebody has scoliosis or not. 10 to 15 degrees, you tend to follow these people through puberty. Once they're through puberty and done with their growth phase, they're pretty much run the gauntlet. 20 to 40 degrees usually initiates not only closer follow-up, but treatment in the form of bracing. And then 40 to 50 is where surgery becomes a major consideration. Once again, surgery is a big issue because surgery is a big thing. It's a multi-level fusion. It requires titanium rods, pedicle screws. It's also difficult that if you're trying to follow something like a Syrinx or something in the spinal cord, it makes it so it's very difficult to see that structure on an MRI scan. So everything about a fusion makes our life in following these patients a little more difficult. So conceptually, the way I think about this is all around about 4 weeks. So about 4 weeks after conception. And at 4 weeks after conception, you go from this flat plate, which then rolls into a tube. And that flat plate of neural tissue rolling into a tube is called neurulation. So if you have an issue before 28 days, before neurulation, the cord remains open. And that's when you see your true spina bifida, your myelomeningocele. And that's basically where you see that flat plate of neural tissue that's at the skin surface. So when we see these children, you have neural tissue, abnormal skin, normal skin. And surgically what we do is we roll that into a tube and close it and try to reform a tube. And then try to protect it so it doesn't retether. Those are called open neural tube defects. Everything after the point at which that closure occurs is called a closed neural tube defect. Your Chiari 1s, your diastems, your Syrinxes, your tethered cords, your lipomatous malformations. So that all fits basically into the category of closed neural tube defects. The big difference with open and closed also is an open neural tube defect is a problem of the entirety of the spine, entirety of the neural axis, brain, brainstem, spinal cord, and that's not the same with closed neural tube defects. So they're very, very different problems. Throughout this, when I mentioned Chiari 2 is an open neural tube defect associated problem. When you have an open neural tube defect, you have a Chiari 2 malformation. So Chiari 2 is basically indicative of the presence of an open neural tube defect. Chiari 1, closed neural tube defect. And here you see that when you're talking about open neural tube defects or myelomeningocele, it's at the very bottom, the posterior neuropore, that closes about 27 days, and that's where you tend to see beforehand open, after closed. And some people can ask me questions afterward, but this is my very simplistic approach to neural tube defects. Basically, we look back at a number of patients, those with open neural tube defects and those with closed neural tube defects, basically as I've defined. Every patient had surgery for that neural tube defect, whether open or closed. So they had a primary neurosurgical procedure. They were then followed to see if they needed surgery for a fusion or didn't need surgery for a fusion. And we've tried to figure out what factors that were present before that fusion surgery led to them likely needing a surgery. So trying to figure out how we can explain to people early on in the process that you are likely or not likely to need a fusion of your spine. So we looked at our patients over the last 10 years, and once again, those in the surgical fusion group already had a neurosurgery, and then they progressed on with regard to their angle to approximately 50 degrees, requiring a surgery. Those in the non-surgical group had the initial neurosurgical procedure and then didn't need surgery. The consideration, there's one surgeon doing all the surgeries, that was me. These were all open neural tube defects that were not closed in utero. So these were all patients that were delivered and then the neural tube defect was closed, the myelomeningocele was closed. And most of the tetherings were complex tetherings. Tetherings from lipomatous malformations, tetherings from myelomeningocele. Because those are the surgeries that are more difficult and the problems that are more concerning for us. Chiari decompression is unfortunately kind of standard and kind of not. And people will spend weeks disagreeing on how to and how not to do surgeries for Chiari malformations. I tend to take a very simplistic approach. Our incisions are probably about 4 centimeters in length. The way we approach it is this angle looking up and down. You need a lot of variability. Side to side, not so much. We don't just remove the back of the bone at the base of the skull, we take it far laterally, because bringing it far laterally buys you more room. And this is something we do in skull-based surgery all the time for adults. That's the way we get to tumors. That's the way we come from behind to get to the tumor in front of the cord, in front of the brain stem. So I've just kind of applied that technique to Chiari malformations. So I don't believe it's as high as you take it. We probably take it about as high as a thumbnail, but I think it's how wide you take it. And one of the good things about that is you don't ever overdo it. You don't ever get these cerebellar slump syndromes afterwards because you've removed too much bone, because we don't remove too much bone. Whether we take off the ring of C1 or not is all based upon how low the tonsils are. If the tonsils are low below C1, we take off C1. If the tonsils aren't low below C1, we leave it alone. The only time we use grafts is if the patient has a syrinx and during surgery on ultrasound, we don't see good movement of fluid. They have a syrinx, we don't see good movement of cerebrospinal fluid, we'll remove the dura and we'll put a graft in. Otherwise, we don't. And it's really kind of a simplistic concept, is at the base of the skull, you have the foramen magnum, you have a hole. The only thing that should be in that hole is your spinal cord. As you know, Chiari malformations, the tonsils, the cerebellar tonsils, which is just a lousy name because it confuses a lot of people, are also in that hole. So it's basically a problem of too much stuff in too small a space. And the way we treat it is to make that space bigger. People are going to argue on what you do to the people in that space, the tonsils. Do you cut and remove them? Do you shrink them? Do you leave them alone? And people will argue for days, months, and years about this. In kids, it's very rare that you have to do anything to the tonsils because the tonsils are somewhat more mobile. They're not as scarred, and it may just be that you're catching them early on in the disease. Adult tonsils are different, and that's, I think, where most of the problem comes up, but you'll hear pediatric and adult neurosurgeons argue all the time about what you do and what you don't do to the tonsils. This is just my simplistic approach to this. So these are all the characteristics between the two groups, between surgical and non-surgical, and of all of the things we looked at, gender, age, tethered cord, Chiari 1, Chiari 2, curvature and such, the things that we found that were most notable and different in the groups is that the patients that required the initial neurosurgical procedure tended to have a more likely finding of urinary problems. One of the problems we find with tethered cord is the bladder is a muscle, and the way the bladder works is the muscle contracts, allows you to get rid of urine. If you weaken that process, then every time you urinate, you don't get rid of 100% of the urine. Maybe you're getting rid of 80%. And over time, that adds up, adds up, adds up. Pretty soon that urine can move up the ureters and into the kidneys. So it's a big problem if somebody doesn't have complete emptying of their bladder, and that's why that was something that was significant for us. The other finding was sensory changes, that the sensory changes were present and they were different from baseline. And these were the two things that really kind of separated the patients that had initial neurosurgical intervention or didn't in overall populations. There were 15 patients, 8 females, 7 males, that had neural tube defects and scoliosis. All of these patients underwent an initial surgery for the neurosurgical problem, for the neural tube defect problem. 6 of these were open neural tube defects, 9 were closed, and that's just based upon the definition I gave earlier. 10 of these patients had what we called complex tethered cords. Open neural tube defects, myelomeningocele, were a great deal of surface areas attached to skin or dura or other things creating the tethering. 4 had Chiari 1 malformations, 6 had Chiari 2 malformations. Once again, the 6 with Chiari 2 malformations are open neural tube defects. 11 of these patients had syrinxes associated with the neural problems. The average age at the time of initial surgery was 7.4 years of age, and that's when we addressed the neural issue. The results following the initial neurosurgical procedure, and these are all patients with some degree of scoliosis, nobody had improvement in their scoliosis. One thing we always historically tell patients, you'll either stay the same, which is a good outcome, or get better, which is a good outcome. It turns out we probably weren't real accurate, at least in this series, because nobody had improvement in their curve or reversal of the curve. On the other hand, 8 patients had stabilization of their curve. Less than 10 degrees change, which is a big thing because it means you very likely won't need a big fusion surgery down the line. 7 had worsening greater than a 10%. Now that worsening, once again, doesn't mean you're going to need a fusion surgery, but if that 10% leads you into that realm of 50% of, or 50 degrees of angulation, then it does, and that's problematic. We did find out that the groups that ended up needing fusion had a worse curve at the start than the others. So before they underwent the initial neurosurgical procedure, they had a worse curvature of their spine than the patients that didn't need fusion. When you look at those with open neural tube defects, not only was there a larger pre-surgical difference in how many degrees of angulation there were, but after surgery, they had the greatest change in progression. So they changed or curved more rapidly. And more rapidly than when you look at the closed neural tube defects, the Chiari 1s. Chiari 1s after surgery only had 6 degrees of change. So Chiari 1s responded very positively to this type of surgery when they also had a presence of an angulation of the spine. Tethered cord alone, 11 degrees. And these were found to be significant. This is kind of a busy plot, but this is looking at everybody in the series and kind of where they went. And this is the change in the Cobb angle after the initial surgery. You can kind of see that dotted line at the upper part with the triangle. And those are basically, or one patient basically with an open neural tube defect. All the triangles are open neural tube defects. When we break this down, which I'm going to do, it basically helps us determine that open neural tube defects, or Chiari 2s, are the bigger problem with regard to this type of need for fusion. This is looking at these angles before the neurosurgical procedure. And you can see those that required surgery on the right, those that didn't on the left. Not only did you have more angulation in those patients before surgery, but there was a much wider range. That's both good and bad, because the increase in angulation gives us a sense that they probably will need surgery. The larger range can make it more difficult to figure, even though it's an increased angulation, who in that group is going to be more likely to need surgery. So there is some clarity, but there's also a lot of confusion. This is a little clearer when you look at the magnitude of the curve of their spine over time. Pre-neurosurgery, there's obvious difference between those patients that eventually needed fusion and not. Post-neurosurgery, you see that is an even greater finding. And then the last follow-up before they actually had the fusion, there's a significant difference. And you can see that the curvature is remaining pretty stable with really a minimal increase in those patients that didn't need fusion, but it not only increases significantly, but it also increases rapidly in those patients that did need fusion. So result of 15 patients, the mean age was 7.4 years. 7 patients didn't require fusion, 8 did. There was no real difference between the age or follow-up in these patients. So from that standpoint, the populations were pretty symmetrical or equal. Following our intervention, as I just discussed before, no patient had improvement. 8 patients had less than 10 degrees of change, and 7 patients had progression greater than 10 degrees of change. 6 of 8 patients who curve stabilized were in the non-surgical group. 6 of 7 who worsened by greater than 10 degrees were in the surgical group. So usually those that increase by more than 10 degrees are going to probably end up needing surgery. We then used a univariate analysis where we basically took all of these different variables and tried to use those things to figure out what were the differences between these populations. Sex, there was no difference. Age, there was no difference. The presence of a tethered cord, no difference. The presence of a Chiari malformation, type 1, no difference. Patients with open neural tube defects, there was a significant difference. With regard to a Syrinx, 11 patients in the group, between the two groups actually had a Syrinx. 6 were in the surgical group, 5 in the non-surgical group, which was not significant. 5 of 6 patients with open neural tube defects who had a Syrinx and a tethered cord. 6 of 6 patients with open neural tube defects required surgery. So everybody with an open neural tube defect required surgery, whether they had a Syrinx or not. Risser grade is just another way of determining angulation and need for scoliosis. It probably doesn't need to be talked about at this time, but it also was significantly related to whether they needed surgery or not. When you look at the distribution of the curve, whether it's thoracic, thoracolumbar, lumbar, lumbosacral, there was no difference. So where the curve was didn't help us predict the need for surgery, and that was no help. We also noticed there weren't a lot of atypical curves. So we're looking at curves that kind of go off to the side, scoliosis, not curves where you're hunching forward, which is a kyphosis. We didn't see a lot of kyphosis in this population. what we saw was mainly scoliosis. And in the entire cohort, there are only 4 people with double curves. That means it's just not one angulation, but forms kind of an S-turn. So we found out that the presence of these S-turns and where the scoliosis occurred really were not indicators of whether somebody would need a fusion or not. So those patients that needed fusion had larger curves before initial neurosurgery, had a greater degree of change after neurosurgery between the surgery and then the need for fusion, had larger curves from the get-go, so they were more curved. And lastly, as I'd been talking about before, those with open neural tube defects had much more curve progression than those with closed neural tube defects. So there's something just inherent about open neural tube defects, at least in our experience, that is more likely to result in the need for a fusion downstream. There were no non-surgical patients with a Cobb angle greater than 30 degrees. So of all the patients that didn't need surgery, nobody started out with a significant angulation. Closed neural tube defects with a Cobb angle before neurosurgery of less than 30 degrees only needed fusions in 12.5% of the time. And that's when they reach 50 degrees. So even having a closed neural tube defect, if your angulation is less than 30, you're likely not going to require surgery. Patients in both groups, the fusion and non-fusion group, both had similar surgeries for their primary problems, whether it be a Chiari malformation, a tethered cord, lipomatous malformation. Complications, 2 patients of the entire series had cerebrospinal fluid leaks requiring surgery for closure. 1 patient with a fusion. In both groups, the wound broke down and required surgery for closure. Discussion, there's not a lot of literature that deals with this. And that's why we've made this attempt, which is retrospective and fortunately kind of a poor attempt, but it was initial movement into trying to figure out if we could predict the differences. But it's not something that's being dealt with extensively in our own literature. We don't know what the mechanism for angulation is. So we're just hypothesizing what the underlying issue is in the first place when you have a neural tube defect. There are a couple different hypotheses. One is that the presence of Syrinx can create or result in curvature of the spine. It's felt that despite the fact that a Syrinx is a symmetrical, for the most part, opening of the central canal, fluid canal in the spinal cord, that this creates an asymmetry. That this asymmetry can lead to more muscle pull on one side than the other, and then this can result in curvature. Syrinxes are usually found in 20 to 90% of patients with open neural tube defects. And so this is a cut, if you cut like through a banana and you're looking inside of it, this being the spinal cord, that being an initial opening, that's not what I would call a Syrinx, but basically when you can see the central canal, it's just an enlarged central canal, it's not a Syrinx. That's a Syrinx. And for some reason, the symmetry of a Syrinx doesn't manifest itself in that fashion. It creates an asymmetry of signal. The other consideration was tethered cord. And the point basically being that where the point of tethering occurs, that the oxygenated blood getting to the neural tissue is lessened at that point. So you have essentially an ischemic environment. For some reason, that ischemic environment leads to asymmetry of signal once again. Asymmetry of signal, curvature. So those are 2 of the primary hypotheses. So the consideration then is having both of these potentially could put you at a greater risk for needing a fusion surgery after your neurosurgical procedure. And that's one consideration, but we don't know if these are actually correct or not. And it doesn't explain all of the different types of problems we have with like split cords. Those are considered tethered at times, not tethered at other times. Sometimes a split cord can end in a lipomatous malformation on one side and not on the other side. So there's a lot of disparity with closed neural tube defects that don't help us explain these things. So we do know that initial neurosurgical intervention, decompression of a Chiari malformation, dealing with the Syrinx, initially by the Chiari decompression and seeing if the Syrinx goes away. If it doesn't go away, the next step is to basically go into the Syrinx, and I put a small catheter that extends from the inside of the Syrinx to the subarachnoid space, basically something that equalizes pressure. The catheter is not so much of a shunt, but keeping that hole and that conduit open. We do know that this can stabilize neurologic symptoms and improve neurologic symptoms. It can stabilize angulation, curvature, but not improve that. The effect of the associated spinal deformity has provided really mixed results. The younger you are and the more curved you have at presentation help predict whether you're going to be more likely or not to require a fusion. We had 4 patients with Chiari 1 malformations who also had a Syrinx. 1 was in the surgical group, 3 in the non-surgical group. The 3 non-surgical patients all had angles of less than 20 degrees prior to surgery. That being said, you have a Chiari type 1 malformation and not a lot of curvature at the time of your initial neurosurgical procedure, which is the decompression, then the chances of you needing a fusion for angulation are pretty slim, even in the presence of a tether, even in the presence of a Syrinx. The age distribution in the non-surgical group was more varied. This just means in a small series, it's kind of more difficult to make assumptions based upon the way we did the study. There was 1 non-surgical patient that had an isolated Syrinx. An isolated Syrinx means you have a Syrinx that's not associated with the tethering. You give a contrast eye and MRI, you're looking for a tumor. You don't see that. You can then do a study where you can look for blood products called a SWAN study to see if there's a vascular malformation causing it. We didn't see that. So this was truly somebody with a Syrinx that we had no real reason that we could determine why it was there. Patients with scoliosis due to lumbar and sacral tethered cords can benefit from untetherings and stabilization of the curve. So if you have a tether, whether it be a simple tethered cord or a tethering from a lipomatous malformation, or Chiari, because I almost consider Chiari to be a tethering, then surgery for all of those disorders can result in stabilization of the curvature of the spine. And that's important because you're trying to prevent a much larger surgery, once again, in fusion. Open neural tube defects. All 6 patients with open neural tube defects required fusion. So everybody with a mild meningocele and a Chiari 2 required fusion. All 6 had tethered cords, which is almost by definition. 5 had Syrinxes present. All of these patients had the largest pre-surgery angulation, especially when compared to Chiari at 23 degrees and tethered cord alone 21 degrees. Patients with open neural tube defects also had the greatest magnitude of curve progression after surgery compared with Chiari 1s and tethered cords. There was no increase in the incidence of atypical curves, and I had said that before, is we weren't finding kyphosis in addition to scoliosis, and we weren't finding these S-shaped curves or these kind of double scoliosis. There was no difference at the age of time of surgery between these patients, Chiari patients and tethered cord patients. When you look at angulation, of the surgical group, 7 patients had tethered cords. But once again, 6 of 7 were open neural tube defects. All 7 underwent fusion surgery or progressed to surgical range after the neurosurgical intervention. Their pre-neurosurgery Cobb angles were greater than 30% in 5, or greater than 30 degrees in 5 of 7 patients. And I basically am not talking about the risks or grade in this talk. We did not see a large number of atypical curves, as I had said before. We felt that skeletal maturity was not a predictive factor for the stabilization or the progression of scoliosis. In those patients that ended up needing a fusion, bracing didn't work as an alternative. Bracing was attempted as the curvature progressed, but didn't really answer the question, with 4 of 5 patients that had bracing still progressing to surgery. All 4 of those patients had open neural tube defects. Patients with angulation less than 40 degrees and Richter scores grade 3 to 5 at the time of neurosurgery were more likely to have stabilization after untethering. Scoliosis patients with curves less than 35 degrees that also had a tight phylum or a tethered cord who underwent untethering also were less likely to progress. So what we found is what many people have found is that Chiari decompressions, treatment of Syrinx, whether with or without a Chiari, treatment of tethered cords, all when you're dealing with closed neural tube defects, does have a significant impact on trying to avoid the need for a fusion. And so that's an important message. The same can't be said for open neural tube defects, because open neural tube defects are much more problematic. But if you think back, open neural tube defects are problems of the entire neural axis, so we know that they're going to be more problematic. So those variables correlating for the need to fusion. If you look at all of this and you look at Chiari-2's open neural tube defects, if you have a curve of less than 30 degrees, the majority of patients didn't need a fusion. So that's the good news at the time of initial surgery for those patients with open neural tube defects. If you had a curve of greater than 30 degrees, everybody required fusion. If you had a Chiari-2, everybody required fusion. If you had a Chiari-2 with a greater curvature, everybody required fusion. So open neural tube defects are probably much more of a problem. So considerations, there's so much complicating issues when you're dealing with neural tube defects, because there's relationships of many things that make it very difficult to separate these things out. Syrinx with or without tethered cord, Syrinx with or without lipomatous malformation, Syrinx with Chiari-1, Syrinx with open neural tube defect. It's hard to separate these things out and get a predictive model to really get an honest answer to what these variables actually mean when you try to isolate them. It's also problematic in that not everybody follows the rules that you come up with. And there were patients that fit into what we thought was a predictive model that didn't end up needing fusion surgery, and that made it a little more difficult. The conclusion, there's no doubt that there's an association between neural tube defects and scoliosis, more so for open neural tube defects than for closed neural tube defects. In the case of Chiari-1 malformations with the Syrinx, decompression is indicated. Once again, dural grafting is really based upon intraoperative ultrasound for me. Some people don't use intraoperative ultrasound and graft everybody. That's right. Ultrasound is right. We don't know what right is, so I think the way everybody does it is right. Neurosurgical intervention may prevent curve progression in patients with scoliosis and curvatures less than 30 degrees if they don't have an open neural tube defect. Patients with open neural tube defects are at a higher risk for fusion, and I've kind of beat that to death. In patients with open neural tube defects, we recommend neurosurgical intervention followed by close radiographic follow-up, just because it's very likely they're going to need a fusion. You need to follow them closely. Thank you.